we move on to the fourth session of the day. That is the therapeutic uses of endoscopic ultrasonography. We know once the ducks have given birth to ducklings, ducklings have something to do. They'll start fishing for their food, they'll keep roaming around, and for their own survival, they will look for something which is different from their mother who has given the birth. So once Dr. Vipul Rai Rathore has established the basics, nuances of endoscopic ultrasonography, we have the birth of Dr. Vinay Dhir, who have crossed all the boundaries and taken us to a greater heights of intervening into the hepatobiliary region, not for diagnosis, but being a competitive person for the surgeon. So with that, I'll hand over the proceedings to Dr. Vipul Rai Rathore, please.
Thank you very much, Anil, and it was a great honor and pleasure to see a wonderful conference going on and great proceedings. Thank you very much. As you have mentioned well, that the natural progression of endoscopic ultrasound was intervention and therapeutic. And when we talked about intervention, we talked about initially tissue acquisition, and that's where we started our journey. And we now are in the era of serious therapeutic EUS. So today we have none other than my friend and colleague from Mumbai, Dr. Vinay Dhir. For his introduction, I would like to say he's one of the prominent leaders in India and across the world in endosonography, and he is currently the director of the IDL, that is the Institute of Digestive and Liver Sciences at SL Raheja Hospital in Mumbai. So Vinay will be taking us through the journey of therapeutic interventions and the newer horizons. To join us on the panel, we have Dr. B.K. Agarwal from Patna, a senior gastroenterologist. We also have Dr. Sandeep Sidhu, who is a professor and head of the Department of Gastroenterology and Liver Transplants at Dayanand Medical College and Hospital in Ludhiana. We have Dr. Bharat Bhushan Gupta, a dear friend and a senior gastroenterologist from Jammu. We also have Dr. Sharad Chandra, who was at PGI Chandigarh and now has located himself in a place called Jhansi. And we have Dr. Satyarth Chaudhary, who is also a leading gastroenterologist, young, dynamic gastroenterologist who have learned the ropes of EUS and has been actively performing interventional procedures. He is well trained in all aspects at PGI and other institutes. So I welcome all my panelists on board today, and I would invite Dr. Vinay Dhir to start his proceedings, as we are already about 20 minutes behind the schedule. So please, Vinay, can I have you, Vinay, on board?
Yeah, Vipul, can I again request you at the cost of repetition to just stick to the time?
Yeah.
Thank you, Vipul, for that kind introduction. Thank you, Anil, Dr. Anil Arora, for giving me the opportunity to be with you all this evening. This has been a fantastic conference, a really high value, high educational output conference, and congratulations for the great success, not only this weekend, but the previous weekend also. So my job is to talk about therapeutic EUS. And okay, so therapeutic EUS, as you all know, is going on slowly from last 2 decades, but has picked up speed really in this decade. And this decade can be called as a golden era for therapeutic EUS. Not only because we have got lots of new tools to work with in therapeutic EUS, but also there have been some excellent publications in the field. So with this wonderful mix of therapeutic endoscopy and interventional radiology techniques, therapeutic EUS has really taken strides and has established a niche for itself in all advanced pancreato-biliary units across the world. It has really changed the way we manage certain disorders, and that is what is the scope of my talk today. We will discuss areas where therapeutic EUS has already caused a fundamental shift in our approach to management in the past few years, and we will review a few important publications in this regard. So this was a review we published almost 6-7 years back, and these are the indications, potential indications for interventional EUS. Indications remain more or less the same over the past decade or so. Ductal drainage, bile duct and pancreatic duct, drainage of fluid collections, pancreatic fluid collections, perirectal collections, liver abscesses, cancer-directed therapy like alcohol ablation, radiofrequency ablation, brachytherapy, and then of course, celiac plexus neurolysis, coil injection for gastric varices. Mike just now discussed about gastric varices. It's a very important area which I will not discuss for shortage of time. What is the evidence that we have accumulated for all these indications? For PFC drainage, we have a level 1 evidence now. For biliary drainage, we have a level 1 evidence. For celiac neurolysis, yes, we have level 1. But for others like pancreatic duct drainage, RFA, coil and glue, perirectal abscess drainage, probably we need more evidence before we can confidently say that there is a paradigm shift in the management because of EUS guided therapies. So apart from the techniques which have evolved, the technology has been a major boost to us. The companies have been making all kinds of new stents to help us give better patient cares and better outcomes. And this has been a real change in the last decade. So not only is the technique evolving, the technology also is evolving in parallel. And I think that makes the procedure very exciting, and the outcomes are improving. And of course, the most important things that has happened in the last 7-8 years is the development of what we call as lumen opposing metal stents or biflanged metal stents. These are small dumbbell shaped stents with wide flanges, and these have really changed how we look at various things like collections or even crossing boundaries from the stomach to the jejunum, bile duct. So things have really evolved because of the availability of these technologies. Let us discuss a few areas in this. So before EUS-BD came on the horizon, EUS guided biliary drainage, a patient who failed ERCP would go for PTBT. That was the standard situation. But that paradigm has shifted. At expert centers, if you fail in ERCP, now you just change your scope and you do attempt an EUS-BD first. And we are very confident in doing this because a good literature has appeared in the past 5 years. We have a level 1 evidence regarding efficacy and safety, and comparative studies of EUS-BD, not only with PTBT, but also with ERCP. So a quick video for you. You all know, so this is dilated biliary radical. We evaluate, this is the segment 3. We go in, see, you find a good radical, and then after doing the Doppler, you puncture. This is a good scope position, check the scope position. Then once you puncture, you see, aspirate that you are in the bile duct. Once you have aspirated, then inject contrast to know where you are. And then you pass a thin guide wire, a Terimo or a Visiglide. So you see that this is how the duct is going. So it's a subhilar stricture, and we are trying to pass the wire. And once you are able to pass the wire, pass a 6-foot cystotome across. So after we coil the wire here, we pass a cystotome. And once the cystotome is in place, we can then direct the wire across the stenosis. So the wire goes across the stenosis into D2, and then the cystotome follows, and we change the wire. So these are all things we have learned from our radiologist colleagues. They do exactly the same thing. They have been doing it for decades. Now we are doing it with an endoscope. So learning from our colleagues in radiology. So this is a Soindra dilator, a 10 French Soindra dilator going through the stricture. Stricture is very tight. Once we have dilated, then it is easy to place a stent which we use for ERCP, an uncovered expandable metal stent. So using both endoscopy as well as interventional radiology techniques to help the patient and place an expandable stent. So this is called as antegrade procedure. There are many other procedures within EUS-BD, about 17 or 18. I will not go into the details of all, but suffice to say that we have now a good technique available to us, not one, several techniques. So we were shown by this meta-analysis from the New York group, Sharaya, 9 studies with 483 patients. And while the success rate of EUS-BD and PTBT remains the same, EUS-BD has fewer adverse events and lower rates of reintervention. Not only this, there were 2 randomized trials which showed the same thing, that there is similar success but higher rates of reintervention and adverse events with PTBT. So wherever you have expertise available, shift from PTBT to EUS-BD in patients with failed ERCP. Patients who have duodenal stenosis or post-surgical anatomy fall in the same category. You should use EUS-BD before you refer your patient for a PTBT. In 2015, we published this first study which compared EUS-BD and ERCP for distal malignant obstruction, and we showed that there was no difference between the efficacy and adverse events of the 2 procedures. Following that, initially it was a very, I got a lot of letters on this, but later on you see in 2018, 3 randomized controlled trials have come, which have shown us that the success rate of EUS-BD and ERCP for distal malignant obstruction is comparable. There is no difference in the adverse events, except in the Korean study, where paradoxically ERCP has a higher adverse event rate. We believe that ERCP and EUS-BD are comparable. I would not say EUS-BD is superior, but they are comparable for distal malignant block. And as of today, we use ERCP as the standard approach, and we use EUS-BD after ERCP failure. EUS-BD only becomes the first line in patients with post-surgical anatomy or where there is a significant duodenal stenosis. So this is a paradigm shift that therapeutic EUS has brought in the field of biliary drainage. Let's come to pancreatic fluid collection drainage, and we already know from papers published by Sham in 2007 that EUS guided approach is superior to a plain endoscopic approach. With the availability of lumen opposing metal stents and biflanged metal stents, we also have got good evidence that these stents allow for necrosectomy of one. And although it remains controversial, by and large, it is accepted then that when you need necrosectomy, you should plan for a lumen opposing metal stent or a biflanged metal stent. And the paradigm that has changed is that before all these stents were available, what we would do is place 1 or 2 plastic stents, and they would be there in the body for 3 months, 4 months, 6 months, or maybe longer, because there was a paper randomized study from the Belgium group in 2007 by Arivantikis, which showed that if you remove the stents early, there is likely to be a very high incidence of recurrence because of disconnected pancreatic duct syndrome. That paradigm seems to be changing. A quick video if we can. So this is a nice homogeneous collection. You evaluate, look for the vessels, see the distance from the stomach wall, measure the cyst, and then use a 19 gauge needle. I'll go through fast. Pass the needle, pass a thick wire, 035 wire, and then dilate with a cystotome and a 6 mm balloon if needed, and then place a stent. Straightforward technique, should not take much time, and the outcome is pretty good. The procedure is pretty fast, and this is a real change for those of us who have been living with the other methods. You know, we have done the endoscopic method. This is pretty easy and more effective in drainage. So this last year, there was a randomized study published by Shyam Varadarajulu in Gastroenterology, which compared, a very important study, compared EUS guided drainage versus minimally invasive or laparoscopic PFC drainage, and they showed that the adverse events were significantly higher in the surgery group, and the length of stay and length of ICU stay was also significantly longer in the minimally invasive group. So this shows us that EUS guided approach should be the procedure of choice for pancreatic fluid collections requiring drainage. So this has been a landmark, very, very important paper. Before this, we were the first to show, this was an article published in GIE, that it is not necessary to leave the stents for 3 or 4 or 5 months. In fact, you should remove these stents early. So this was our first study which showed that you should remove these biflanged or lumen expanding stents at 3 to 6 weeks of time. And this has become a standard approach. So that was a paradigm shift. We don't keep the stents for very long inside. Then we did a prospective study. This was published in Endoscopy. We wanted to see the impact of disconnected pancreatic duct syndrome on the recurrences, 88 patients, and we showed, in contrast to the other studies published before, that the prevalence of disconnected pancreatic duct is very, very high. It's not low. So probably before this, what was being done is that we were picking very few disconnected pancreatic ducts. In this study, we did MRCPs and ERCP in all patients. And we found that disconnected pancreatic duct is much more common than what has been suggested. But a pancreatic duct stent placement does not help, and recurrences are not very high in these DPDS syndrome. We classified them into 4 types, and we also discussed that it is probably not reasonable to expect that a permanent indwelling plastic stent placement would help in any of these situations except probably the type 3. It will not help in the other 3 situations. A month back, a large study from Asian Institute of Gastroenterology, AIG, Basha et al., published in Gut, has confirmed what we had said in 2018. This is a much bigger study, 2,074 patients. You see, 73% of their patients had disconnected duct, while we had 61%. You see the recurrence. So you would expect that 74% of these patients would have recurrence because they have disconnected duct. But the frequency of recurrence is only 13.2%. Of course, it was significantly higher in disconnected pancreatic duct. But the thinking based on these two studies is that not all patients with disconnected pancreatic duct need a permanently indwelling plastic stent within the pancreatic fluid collection. Now that is likely to be a paradigm shift. Again, we are changing the way we have been thinking. Quick things on gallbladder drainage. It's not very commonly done in India because our surgeons are very aggressive, but the procedures are the same. You use an axial stent, don't use a Nagi here, and it's a straightforward 5-minute procedure. We do it from the duodenum, not from the stomach. And we have enough studies to say that EUS guided gallbladder drainage has good outcome and is superior to percutaneous gallbladder drainage, which many of our surgeon colleagues follow if they cannot operate patients with acute cholecystitis. So this is another change that is being brought. We are replacing percutaneous drainage with EUS guided drainage in the field of gallbladder in patients with acute cholecystitis. I'm going a little fast because I think I have to cover one more area that is a very exciting area of EUS guided gastroenterostomy or gastroenterostomy. We published this study in Gut of 20 patients, showed very, very good results. And after that, So there are multiple ways of doing EUS guided gastroenterostomy. I'm just showing you a freehand technique. So you see here, there is a stenosis here. You pass a catheter with a wire, pass the wire deep beyond the DJ flexure, then remove the catheter, place a 7 French nasobiliary drain, and with that drain, you pass a liter, 500 cc's to a liter of water with methylene blue, so that you can see which of the loops is closest to the stomach. So see here, now you are seeing a loop here, nicely, very close. And after that, you use your axios to do a free puncture. See here, this is a free puncture, and deploy the stent. Not very difficult. I will not say it's a very easy technique, but not very difficult. What we have been doing is we have been using the E-Pass tube, which was developed by Professor Itoi, to improve the safety profile of our patients. But this freehand technique also is quite good. So this is a new development. You are making an anastomosis between two different areas of the gastrointestinal tract, between a stomach and a jejunum, or a stomach and a distal duodenum. Very exciting prospect. Small number of studies available. You have patients 10, 20, 30, but you see there is a 74 patient study in 2018. Very high success rate, technical success rate and clinical success rate. There are adverse events, about 10%, 10 to 12% of patients. Most commonly is if there is a perforation, and the patient may require surgery in rare cases. But this procedure is getting established at high output centers, and I believe that we will get studies in the coming few years, and we will be able to offer a very good alternative to a surgical gastroenterostomy. This is fast, this is efficient, and the patient gets discharged the very next day. So a lot of advantages of EUS guided gastroenterostomy. I'm not touching a lot of other areas. Maybe you guys, we can discuss it during the discussion. Portal vein, gastric varices, embolization coil and other things, RFA is another exciting area. Maybe we can leave it for the discussion. So thank you very much, Vipul. You can take over from here.
Yes, thank you very much, Vinay, for an excellent overview of some of the established techniques of interventional EUS. I would like to invite my panelists, and I don't see any of them. Are we? Oh, Dr. Chaudhary is there. I'm happy to see you, Dr. Chaudhary. And we have with us Dr. Bharat Bhushan as well. And we have, I don't see, is Dr. Sudeep there? And I don't see any. So anyway, we'll start with Dr. Bharat Bhushan first. Dr. Bharat Bhushan, if I have to ask you a question on a pancreatic fluid collection, you practice in Jammu. So how often you feel that this is the modality now completely replacing the conventional laparoscopy or surgical intervention or plain endoscopy intervention compared to what you used to practice in the past? So is it a routine procedure now because level 1 evidence is out? What is your take on that?
Dr. Vipul, thank you very much for asking me the question. The problem at Jammu is that we do not have an endosono and we do not have a therapeutic endosono man here. Yeah. So that's a problem. But otherwise, endoscopic drainage we were attempting. And as you know, as has been told by Professor Dhir also, EUS guided approach is superior to endoscopy report. And in endoscopy approach, we had few patients done, but then the success rate was very low, and then the infection rate was very high. But somehow maybe people are not investing, our younger generation is settling in metropolis. So we have a problem that we do not have a therapeutic EUS here.
So this is a genuine challenge, Vinay, as we can see here. that vast majority of even big cities in India are still not having interventional EUS facility. And this, we need to keep this in mind. And I think this only tells us that we need more centers in India. Coming to Dr. B.K. Agrawal, I'm sure at Patna, Dr. Agrawal, you also deal with patients with all these pancreatic fluid collections. So what is your approach in terms of treating them? How would you select a patient for this is for the interest of our upcoming gastroenterologists and trainees and endosonographers who have just started. So what would be your approach? How would you decide this patient needs treatment or this patient can be observed? So what is your protocol on that?
Thank you, Vipul. Actually, earlier we have been doing with the endoscopy and showing the large bulge in duodenum or stomach. And on ultrasonography, we can make out whether there is enough space in between the gut loop and the pancreatic cyst collection, the pancreatic fluid collection. Then we could go ahead without endosono. But with the availability of endosonogram, I think things have become very easy. And now chances of entering any blood vessel is very minimized, and we can know very clearly that how much is distance between the fluid collection and the lumen of stomach or duodenum. I think with this approach of endosono, I think that things have become very easy, and we can put a stent also very easily. Thank you.
So you would say as a senior gastroenterologist that a conventional endoscopic approach should be avoided if there is an endoscopic ultrasound equipment available in your town or city or some center.
Definitely.
Yeah, so I think this is very important because I have had a few suggestions in the past where people have said that we can still do with a bulge and we can do the needful. So coming to Dr. Satyarth Chaudhary. Dr. Satyarth Chaudhary, welcome. I'm sure Vinay has gone through some interesting details on EUS guided interventions in the biliary tract. What are your preferred approaches and why? So if you talk of a technique of EUS biliary drainage, Vinay mentioned about rendezvous, mentioned about antegrade stenting, about choledochoduodenostomy and so many other. What is your preferred technique of EUS BD and why? I can't hear you. You have to unmute. You have to unmute your mic, yeah. Still cannot hear you. Can somebody unmute Dr. Chaudhary? Yeah.
Pranav?
Yeah, you can. I can hear you now. Yeah. Can you hear?
No, it was me. And,
oh, I'm sorry, Anil. Yeah.
Dr. Satyarth, can you hear us?
Sir, can you please hear me?
Sir, now he's okay. He can speak now.
Now we can hear you. Yes, we can hear you. Yeah.
No, again, your voice has gone. Can you not use headphones?
Remove your headphone from the laptop and
yeah, you can directly speak into the mic of the laptop.
Okay, sir. Can you now please hear me?
Yeah,
Audible, sir.
We can hear.
Yeah.
Audible.
So the most preferred approach where I use the cases where the ERCP is unsuccessful, then I go ahead with the Hepatico HGS approach.
Okay.
That is the most preferred for me. And apart from that, the duodenum is also a site which is most preferred and easily accessible. But I have noticed that most of our cases, the duodenum is also involved and HGS is the favorable approach.
Vinay, can you comment on this? What is your preferred approach of EUS BD given a choice?
Yeah. So what we believe, and this is because probably I am a little old from the older generation, that transpapillary drainage is still better than transluminal drainage, although there is no evidence to show that transluminal drainage is in any way inferior. So I would give my first option to either a rendezvous if the duodenum is accessible, or to an antegrade procedure, because in both these cases, in both these procedures, the stent comes out through the papilla. However, if that is not possible, then I will go to hepaticogastrostomy or choledochoduodenostomy, depending on what level of block it is. If it is distal block, I will go for choledochoduodenostomy. If it's a little proximal block, I go for hepaticogastrostomy.
Right. So coming to Dr. Sharad Chandra, one of our panelists, I would like to ask you, Dr. Sharad, that if you have a patient who has a very proliferative tumor in the ampullary area, but it is periampullary lesion, but you can access the ampulla, would you prefer an endoscopic transpapillary stent, metal stent, or you would prefer a USBD?
Yeah, actually, in this situation, if we do EUS-BD, choledochoduodenostomy, we are not traversing the tumor.
Yes.
What has been shown that the survival rate, the patency of the stent is longer if we go transmural. If we go through the papilla, the chances of tumor ingrowing into the stent and blocking the stent are higher. So I think in this situation, I would go for a transmural drainage choledochoduodenostomy.
Okay. Do you feel that for all lower CVD blocks and proliferative tumors, EUS-BD may become a norm than some cases? What is your opinion on that?
Actually, the number of procedures which is being done, except in high volume centers, are not much. So at present day, I think I would still go with transpapillary stenting. But over maybe in a few years, once the expertise and the number of procedures which I do increases, then I definitely would go for the other option.
Okay. I think you answered your question fairly well. I would ask Vinay one more time. I will keep going back and forth with Vinay. So Vinay, tell me, what is the learning curve for EUS-BD drainage to secure a complication rate comparable to ERCP?
That's a very, very good question, Vipul. We assume that people who venture into EUS-BD are already good at ERCP, are having a success rate of 90% and above. So we are assuming that the basic skills of endoscopy, ERCP are there already. And with that, there are studies which have shown that about 40 procedures, 40 EUS-BD procedures are what you need to bring down your complication rates to acceptable, that is single digit levels. But now when you say 40, there are different EUS-BD procedures, and each of them have a different technique. Choledochoduodenostomy is different, hepaticogastrostomy is different, rendezvous is very different. So I would say probably 40 is when you start feeling confident about your scope position and that you will manage. But to be very, very good, I think you will go to around 80 to 100. Then you are good.
So if you want to do 40 to 100 EUS-BD, how much time a trainee needs to spend in a unit and in a busy unit?
Oh, that is very, very difficult. So
we are touching some of the nerves.
Yes.
There are challenges, and it's very exciting and very, very glamorous. We all know that. Coming to Dr. Sharad again, Dr. Sharad, we heard very eloquently from Dr. Vinay about gallbladder drainage. Do you have any experience in your practice of gallbladder drainage? And which are those conditions where you feel it has salvaged the situation?
Actually, gallbladder drainage is indicated acute cholecystitis in patients who are very poor surgical candidates, either as a bridge to therapy or as a destination therapy, where the life expectancy is not much and the patient cannot undergo definitive surgery. So usually in our practice, actually, if we convey them that it is a bridge therapy, usually the patient don't accept it as the drainage procedure. Whereas those who are frail and unlikely to undergo surgery, they definitely, yes, they do agree for this procedure. Besides this, other indication is anybody already having a percutaneous cholecystostomy, we can internalize it with the gallbladder drainage. And as an alternative to EUS-biliary drainage, if you cannot do a CDS or a HJS, this is an alternative modality for drainage.
Right.
You gallbladder drainage.
Right. Well, as Vinay mentioned very early in his talk in gallbladder drainage, with improved anesthesia and perioperative care, we all know in leading hospitals and even in smaller towns with good ICU backup, the indication for gallbladder drainage, I think our surgeons are still holding on to laparoscopic cholecystectomy or percutaneous drainage. So these are some of the areas where we have, as gastroenterology endoscopists, have challenges to convince our colleagues. And I'm sure this is across the board of all our panelists today. Coming to question, is Dr. Sidhu on the online? Is Dr. Sidhu? Can Dr. Sidhu come in?
I don't think he has joined.
He has not
He's
joined.
not joined yet. He has not joined yet.
He has not joined. So I will go back to Dr. Satyarth Chaudhary regarding a question on gastroenterostomy. So Dr. Satyarth, how easy or how difficult you feel is gastroenterostomy EUS guided? For our young participants today, I want you to share your experience from your perspective.
Again, there is a problem with your voice,
Sir,
Satya.
please remove that. Please remove your wire.
Can you please hear me?
Yeah.
We can
Yeah.
hear you.
So I have a brief experience of 4 to 5 cases of gastroenterostomy done, and it is an excellent technique, but there are certain points which need to be remembered by the initiators. For example, if a person who is doing the US guided GJ, that he has a very good experience on the biliary drainage first, rather than directly jumping to the GJ, which is itself a difficult procedure in terms of the placement of stent, how to release the stent successfully. I feel that is a crux. And secondly, to know the indications, because the recent articles, if you go through them, to me, practically, these are the malignant biliopancreatic obstructions which are causing the gastric outlet obstruction. So there it is actually required, because such patients with high comorbidities, they cannot be the good candidates for surgery. So I feel it is exciting and it is going to develop in such particular subgroup of patients.
I think I'll go back to Vinay on this. Vinay, would you suggest a needle-guided approach to placing a gastroenterostomy stent, or you go direct with hot axios? What is your preference and why?
So we are using a hot axios directly because initially we tried with a needle approach and we thought that it actually hampers the placement of a stent properly. So we have given that up. We don't keep, because if you place a wire, you feel safer, of course. But then the jejunum is a very mobile organ, and with the wire, the jejunum tends to go away. So we have over the last 15 cases, I have done a hot technique directly without a wire.
And when would you not do a EUS GJ?
One case we had to give up because there were obstructions beyond. So some of these patients have carcinomatosis, peritoneal carcinomatosis. So if there are multiple levels of block, your CT should be able to tell you. So actually one patient I took on the table, passed the thing across and then injected, and I saw there was another block immediately beyond. So we came back. So that is definitely one thing where you should ask your surgical colleagues to find if they are able to do a better job than us. Other than that, you need some, at least a 5 French space to pass your catheter or you to pass anything. If it is a complete block and you're not, which is a very rare situation again, probably that will be one area where we will find it difficult to place an EUS GJ.
So we all know that with this kind of obstruction, patients have massive ascites. Is ascites a hampering factor for EUS GJ?
No, you can drain the ascites and then do the GJ, no problems with that.
Fine. So coming back to Dr. Sharad, we will now go to another area where probably on infected WOPN, we talked about EUS guided drainage or pancreatic fluid collections, and I'll come back to that in specific of EUS guided treatment of infected WOPN. What is your protocol in your unit? Dr. Sharad, are you there?
Yeah. Not all WOPN needs drainage. First of all, one needs to be sure that there is a definitive indication for drainage, which is if there is infected collection or there is a refractory abdominal pain, biliary or gastric outlet obstruction, or there is failure to thrive. So once we have definitely established that this patient needs drainage, then we need to decide, we need to evaluate what is the assessment of the percentage of the necrosis inside the cavity.
Right.
That will decide whether we can manage with plastic stents or we need to use large caliber metal stents. This is a very important that indication and what type of stents. Normally, if there is significant necrosis, we always use self-explanatory, that we use a large caliber metal stent, either Nagi stent or Axios, the other option which is available. But if the necrosis is small, we can go ahead and use plastic stents. Although studies have shown that both plastic stents and metal stents, both of them lead to resolution of the WOPN. But still, most of the endoscopists, we prefer to use large caliber stents with the content of necrosis is high, because it helps us in doing intervention, necrosectomy if required, and there's early resolution of the cavity and the procedure time is short.
Have you ever encountered bleeding doing EUS guided necrosectomy or EUS guided puncture?
Yeah, actually bleeding is
Doppler.
Yeah, actually bleeding is a complication which can occur anytime. Although we always get a CT angio before the procedure and we look into the cyst cap, the WOPN nicely with a Doppler exam evaluation, but still we can have small vessels which we can miss. So everybody encountered bleeding during the procedure, but usually what I have encountered is it was a minor bleed, and we kept on doing the procedure and it stopped. With metal stent, usually there's no problem because with the size of the stent, it presses on the adjacent vessel if it's at the entry point. Right. Whereas if you use plastic stent and we use balloons for tamponade effect, and subsequently we continue the procedure if the bleeding is not much.
Dr. Vipul, sorry to interrupt. We are running short of time, so can you
just give me 2 minutes now?
Okay.
I will conclude. One last question to Vinay. Vinay, what is your wish list for a therapeutic EUS indication getting established with 1A evidence, level 1A evidence in the next 2 years?
So I as I discussed my top indications, and EUS-GJ is something which I believe is very, very important, and EUS gallbladder drainage. We have good evidence for gallbladder drainage, so it should definitely replace percutaneous interventions. But EUS-GJ also, with my personal experience and the experience which has been published, I believe it's a very, very good procedure and should replace surgical or laparoscopic GJ. And these are all major indications, because this will really help lots of patients who are undergoing gallbladder surgeries or GJs for various reasons. So
you still feel that the RFA and other ablative techniques and all these vascular interventions, apart from coils and for varices and all, are still investigative techniques in EUS?
Yes, they are exciting. They are very good techniques, but I am a man of evidence. So till we see a few good studies published, especially for example, gastric varices, I know in India there is a lot of excitement about coil and glue for gastric varices, but we have a very good simple method of using a simple gastroscope and we have been using it for 20 years. So I need to see that this method is superior
than the conventional
gastroscopy. Then I will be very happy.
So I once again would like to thank you, Vinay, and all our panelists for joining us in this exciting therapeutic EUS. I'll just summarize in 2-3 sentences. I think therapeutic EUS is the way forward as far as EUS is concerned. We have exciting applications coming up. And the only problem, as I see, I'm sure all of expert panelists and our viewers will also agree, that we are still trying to do therapeutic EUS with endoscopy accessories and ERCP accessories. And this is a major hurdle. So we need a dedicated platform for only EUS guided intervention. And I think this is the need of the hour. If I have to expand more indications in therapeutic EUS section. Coming to the last point, I want youngsters especially, do not compromise learning ERCP skills at the cost of EUS, thinking that EUS BD is the future, because you need to master ERCP skills to continue your lot of biliary intervention as well as pancreatic interventions, and then supplement it with EUS guided intervention. I hope more and more level 1A evidences emerge in the next few years for upcoming applications and indications. With that, I hand over to Dr. Anil Arora. Thank you very much for giving this opportunity.
Thank you, Vipul. I am very thankful to Vinay and all the expert panel members for taking us through the journey of the recent concepts and the recent status of therapeutic endobiliary procedures. If I have to summarize the talk in one sentence, I think as Vinay very rightly put in, you have to be very good at ERCP, you have to be good at EUS before you venture into this field. Knowing very well that ERCP per se has a 5% chance of complication, so the incidence of complication is almost 3 times that of ERCP. So before venturing, please think and rethink. Unless you have a cool, mature head on a strong shoulder, like what Vinay has, please do not venture into it. I think it will take time before you become competent in it. With that, I am thankful to all the panel members, moderator and the speaker for taking us through this journey.
Thank you.
Thank you, Anil. Thank you. Thanks a lot. Thank you, Vipul. Thanks all friends.